Welcome everyone to the Alberta Association on Gerontology Calgary Chapter's webinar titled The Impact of Ageism on Canadian Society. My name is Chantel Zimmer and I'm the chair of the AAG Calgary Chapter. We're pleased to have you with us this evening. For those of us joining from Calgary, I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in Southern Alberta, and that the city of Calgary is also home to Métis Nation of Alberta Region 3. Before we get started, I'm going to go over a few items. First, this webinar is being recorded and will be publicly available for later viewing. To minimize interruptions and issues relating to bandwidth, please keep your video and audio off for the duration of the webinar. The video and audio controls can be found at the bottom of your Zoom screen, and there you'll also find a chat bubble icon. You can click on this icon to open the chat box, and we ask that you reserve the chat for questions you would like our speaker to answer following her presentation. We'll try to get through as many questions as possible during the question and answer period. If you experience any technical issues during the webinar, please send a direct message to Dorothy using the chat. She's a member of our board who's providing technical support for our webinar tonight. Without further ado, I'm going to pass it over to Sophie Saperja to introduce our speaker.
Thank you so much, Chantel. My name is Sophie Saperja. I'm a member of the Calgary chapter of the Alberta Association on Gerontology. On behalf of the Calgary chapter, I'm just extremely pleased to be able to welcome Dr. Jayna Holroyd-Leduc this evening. Jayna is going to be speaking this evening on the impacts of ageism on Canadian society. Dr. Holroyd-Leduc is an academic geriatrician and professor within the departments of medicine and community health sciences with the University of Calgary. She is the current head of the Department of Medicine and the University of Calgary Brenda Strafford Foundation Chair in Geriatric Medicine. Her research interests include knowledge translation sciences to improve the care provided to older adults. Please join me in welcoming Dr. Holroyd-Leduc.
Good evening, everyone. So I'll just start just going through my conflicts and disclosures. So this presentation is copyright compliant to the best of my knowledge, and I have no relevant conflicts of interest or financial disclosures, and I'm aiming to use person-first and inclusive language in the presentation. However, if you notice any ways I could improve, please feel free to email me. And I will not repeat the land acknowledgement, given we have done this already. So given the title of my talk, I thought we should start by talking about what do we mean by ageism? What is it? So the World Health Organization actually has defined ageism as stereotypes, so how we think, prejudices, how we feel, and discrimination, how we act towards others and even ourselves based on age. So where do we see ageism? Well, there's two main areas for ageism. There's at the structural level and also at the individual level. So at the structural level, it's ways society and institutions reinforce systemic bias against older persons. That could be in policies and practices that support healthcare rationing by age, for example. And it can also be done in ways of decreasing opportunities for older adults to contribute to decision-making. At the individual level, it can be the way an older person actually takes in the negative cultural views of aging and how it results in them limiting their behaviors based on these internalized stereotypes. It also can be in the ways that individuals treat older persons. So it can be patronizing behaviors towards older people. It can be limiting an older person's autonomy around their decision-making, or it can just be limits just in how we allow older persons to participate in various societal activities. So the interesting part about ageism, it actually has a pretty significant negative impact on health. So a recent systematic review done in 2020 that looked at 422 studies found that ageism actually was associated with worse health outcomes across 11 different domains. And you can see from the diagram, the domains are pretty broad, but they included things with the biggest one being denied access to healthcare services and treatments, Also, though it's significantly related with mental illness, physical illness, exclusion from things like health research, it's related to poor quality of life and well-being. It can also result in riskier health behaviors and poor social relationships, as well as impacting actually longevity. And then there's also the concern around cognitive impairment and devalued lives of older persons. Ageism also increases healthcare costs. So a study done in 2020 as well looked at computed healthcare costs of ageism for 8 of the most expensive health conditions in the year, and it was primarily in the areas of age discrimination, negative age stereotypes, and then the biggest cost was actually in negative self-perceptions of aging. So how we feel about aging ourselves can actually impact how we age and have negative impacts on our health. So if we think about this in terms of how is it relevant to Canadian society, so as I'm sure you're all aware, the Canadian population is aging fast and aging faster than many other developed countries. So the proportion of those 65 and older has been increasing significantly since the turn of the century, so particularly starting in around 2010. And by 2015, actually, those over 65 in Canada outnumbered those under 15, and you can see that divide has continued from the diagrams. If you look at it, the black circles are those aged under 15, and the filled in triangles are those aged over 60, and you can see how they're past cross and are continuing to diverge. And actually the proportion of the oldest old, so those over 80, is growing even more rapidly. We consider that also the life expectancy in Canada is the 7th highest in the world, with an average life expectancy of almost 83 years, with it being about 81 years in men and about 85 years in females. That's also a factor as our population ages and people are living longer, and those living well into their 90s and over 100 is going to continue to increase over the next decade or two. So given the issues with ageism and its impact on health and healthcare systems, and the fact that our population is rapidly aging, really addressing ageism should be a main healthcare priority within Canada. So what contributes to ageism? So there's things that can actually increase ageism, and there's things that can decrease ageism. So some of the things that increase ageism is our own anxiety regarding aging, which is often reinforced within society, as well as our fear of death. And then negative presentations of older persons can impact our feelings of ageism. What decreases ageism is positive presentations of older people, having available economic resources to support an aging population. And then overall, from terms of self-directed ageism, the better physical and mental health condition we have, the less likely we are to have self-directed ageism as we age. So knowing this, how can we help address ageism in society? So really what probably some of the most important thing to do is increase opportunities for intergenerational interactions. And that would speak to the fact that putting out positive images of aging can really be impactful in decreasing ageism. So some of the things that have been done in different parts of the world and to different degrees in parts of Canada is incorporation of educational curriculum that includes education about aging. So opportunities for students to learn from older adults and to learn about normal processes of aging. As well, there's been some really novel ideas in terms of including schools or daycares or university domes that are actually situated within seniors' facilities so that they're multi-generation living environments. Other ways is to design intergenerational outdoor spaces, such as parks that include multi-generational outdoor exercise equipment. So there can be equipment that can be quite inclusive and used by a variety of different individuals of different ages. And then also we can make community parks and gardens that are accessible, and you can see from the picture, give opportunities to actually interact in a positive and healthy environment. We also should work more to increase positive presentations of older adults. So in media, including social media, I would say arguably the entertainment industry should take some responsibility in how it presents older people. And I think there are better examples as the our baby boomer population is aging. There's good examples of positive presentation of older adults. It's better than it was, but there's still room to improve. And then role models, older adults being great role models for younger generations. If we focus on the healthcare system and how we can address ageism in the healthcare system, I think an obvious thing is to look at current and in the development of new health policies, how do we ensure that they actually don't promote inequities by age? So taking a critical lens and reviewing policies and making sure that they aren't ageist. As well, similar to what has been done by CHR recently in terms of the inclusion of sex and gender, funding agencies like the CHR should really establish requirements for the inclusion of older adults into medical research. We shouldn't be excluding older adults because often that will impact our ability to offer them appropriate care if they're not included in the studies that we use to inform healthcare decision-making. So if we think about age, it's actually not the best factor to consider in healthcare decision-making, given how variably we all age. So if we think about how we age on this continuum from being very robust to being frail, individuals are anywhere along this continuum, and really how it's going to impact their health really depends on where they do sit on this continuum. So what can we do actually to support people to stay on the healthy end of aging, on the more robust end? So really, we should be doing even more to promote and also participate ourselves in healthy behaviors. And it can be as simple as not smoking, consuming alcohol in moderation, so not to excess, participating in regular physical activity, and the recommendations are currently 2.5 hours a week of moderate exercise, or at least an hour per week of vigorous exercise, and then eating things like fruits and vegetables every day. Now, how did I come up with these 4 things? Believe it or not, there was actually a study done that was published in 2012 in the Canadian Medical Association Journal, where they followed over 5,000 people between the age of 42 and 63 years of age for over 16 years. And they were following them to see how they successfully aged. And by successful aging, they defined it as good cognitive, physical, respiratory, and cardiovascular function, as well as the absence of disability, mental health issues, and chronic disease. And what they found that the people that practiced all 4 of those healthy behaviors, so not smoking, alcohol in moderation, regular physical activities, and eating your fruits and vegetables, if you followed all 4 of those behaviors, you were 3 times more likely to successfully age than someone that didn't follow any of them. And there was actually a clear linear relationship between the number of behaviors practiced and successful aging. So encouraging people in midlife or even earlier to maintain these 4 basic healthy lifestyles can really help improve how we age. And then obviously, if you remember, I said one of the components of ageism, and particularly ageism towards self, how healthy you were in terms of your physical and cognitive health improved or decreased your ageist views against yourself. If we look at level of activity in particular, it may actually be a key to successful aging. So this was a study that was done in Australia, and they looked at over 1,500 people, 50 years of age or older, who were healthy at baseline, and they followed them for a decade. And they defined successful aging similarly to the other study in that it was the absence of depressive symptoms, disability, cognitive impairment, respiratory symptoms, and chronic diseases. What they found is those that engaged in the highest level of total physical activity, which actually at over 5,000 net minutes per week is a significant amount of activity. What they found, though, is that these people that were significantly active were way more likely to age successfully compared to those that were engaged in lower levels, so less than 1,000 net minutes per week. So physical activity in and of itself may be a significant key to successful aging. So I mentioned frailty and how we can age from variably from being robust to becoming frail. What do I mean by frailty, and why is this relevant? So if we look at frailty in Canadians, aging and frailty are not synonymous, but frailty does become more increasingly common as age advances. And you can see from the picture that about a quarter of people over 65 are by definition frail. So the interesting thing is that the decline in health status is actually driven more by frailty than by our age. And frailty itself is what is associated with increased healthcare utilization. Part of this is because we've had quite successful advances in modern medicine. So frailty, in a way, we've kind of created it. So we have increasing longevity. So as I said, the life expectancy in Canada is quite high, well into our 80s. And we've turned a lot of common diseases that used to actually be acute illnesses, we've turned them into chronic illnesses. So we haven't essentially cured them. So basically, people have ongoing morbidity associated with a lot of these diseases. And you can see from them, they're quite, some of our top most common diseases that we've turned from being, relatively what used to be considered acute diseases and where people died a lot younger of them, they now can live multiple decades with these conditions. So essentially, it's contributed to the prevalence of frailty increasing as our population is aging. So what do I mean actually by frailty? And I recognize this audience, you probably all have a very good understanding of frailty, but I know there is some controversy in what people think of as frailty. So when I'm talking about frailty, what I'm talking about is a state of increased vulnerability to adverse health outcomes. It results from reduced physiologic reserve and a loss in function across multiple systems. It reduces the ability to cope with normal or even minor health stressors. And it's associated with increased risk of physical, cognitive, and functional decline, and also with adverse health outcomes, including mortality. So frailty, in my understanding, is not just about physical frailty, but broadly about physical, cognitive, and also social frailty. So we think about frailty in the Canadian healthcare system. Patients with frailty are overrepresented in our healthcare system. So the majority of hospitalized older adults are pre-frail or frail, and older adults account for over 60% of acute care inpatient days. As well, almost all of those in long-term care are frail, at least over 80%, particularly in those living in long-term care in Western Canada. Polypharmacy is associated with frailty. And then, as already mentioned, frailty is associated with adverse outcomes and mortality. So we think about frailty in our current models of hospital care. The interesting thing is aging. So what do I mean by that? It's because we have literature that hospitalized older adults who were ambulatory during the 2 weeks prior to their admission spent only a median of 43 minutes per day standing or moving. So basically, they're when we admit someone to hospital, traditionally, they have become bedridden. Now, there's been efforts recently to try to address this and to encourage mobilization. And why is this important? The reason it's important is because a third of older adults will develop a new disability in activity of daily living if we don't encourage early and regular activity. And half of those that will never recover that function. So essentially, hospitals can be a great way to create frailty and disability. Also in hospitals, about 10 to 50% of older adults will develop delirium in hospital, which can be associated with persistent cognitive and functional deficits, as well as increased length of hospital stay and in-hospital complications, and is associated with higher rates of discharge to long-term care. So what needs to happen in acute care even more consistently than has been some efforts to date is to support the aging population that is utilizing acute care resources. So we need systematic incorporation of elder-friendly practices in hospitals that are basically a holistic approach to care, that have multi-component evidence-informed strategies that prevent delirium, functional decline, and falls, and that also consider goals of care as it relates to their level of frailty, their expected life expectancy, as well as obviously their personal preferences and goals. We think about frailty in long-term care, as I mentioned, the vast majority of people living in long-term care meet the definition of frailty. About 30% of Canadians, so about 150,000 people, are currently living in long-term care or residential care settings. And it's projected by 2035, so just under 15 years, we're going to need another 200,000 beds because of the aging of the population. And I think the COVID pandemic has highlighted the impact of long-term care and the need for long-term care reform to support our older adults. Particularly, long-term care residents as a population are frail with functional and cognitive impairments. They have complex health and care needs. They're nearing the end of life, and they have a high prevalence of burdensome symptoms such as pain and dementia-related responsive behaviors. 40% of Canadians will actually die in long-term care. Therefore, enhancing palliative care in long-term care should really be a priority across Canada. And there are efforts in pockets of Canada and groups that are working on trying to improve palliative care within long-term care. And by palliative care, I mean focusing on symptom management, so physical, psychological, and spiritual symptoms, as well as maintaining quality of life, advanced care planning, and then supporting both the patient or resident and their families in the process. So why are we not offering great palliative care and long-term care? So there is some barriers, and some of them are actually as a result of ageism. So part of it is the unpredictability dying trajectories amongst older adults that are living with frailty. However, barriers to discussing dying with society, and if you remember, one of the barriers or one of the things that increased ageism was our fear of dying. So the fact that we don't talk about dying in society is actually contributing to poorer quality of care at the end of life for long-term care residents. And then a number of other factors that I think the pandemic has highlighted and made worse is high caregiver provided workloads, and then also our over-reliance on acute care resources, as well as a limited knowledge and skill set amongst the workforce in terms of how to deliver palliative care. So if we look at other components of the healthcare system, what about medical education, and broadly speaking, medical education? Is our medical system actually preparing for the aging Canadian population? And I would say no, it is not. If you look at the literature over the last few years, the average number of undergraduate medical education geriatric curriculum hours across Canada was 21 in a curriculum that spans, depending on the medical school, 2 to 3 years of didactic forms of education. 21 hours is all they get in geriatric care. And it ranged from anywhere as little as 4 to slightly higher at 49. The other interesting thing is only 6 out of 16 Canadian medical schools have mandatory clerkship rotations in geriatric medicine, where actual senior medical students are spending time working with geriatricians and others involved in the care of older adults. Very few residency training programs also offer geriatric medicine training opportunities, and even fewer make them mandatory. And if we think it's unique just to the education of physicians, it is not. Geriatric education and other healthcare professional programs is similarly limited. So what needs to happen within the health professions education to support the aging population? Well, we need appropriate focus on educational curriculum, broadly speaking, for all healthcare providers that teaches components of geriatrics, as well as specifically dementia education. And also, healthcare practitioners need to understand normal aging processes and differentiate them from disease processes. We also need to be more systematic in how we incorporate assessment of function within our clinical assessments. So it's often a significantly neglected component of history taking. And without this, we're not really able to understand if a patient is experiencing frailty. And as I said, frailty is really a better predictor of healthcare outcomes than age itself. We need more mandatory clinical rotations within geriatrics so that people can truly understand frailty and its impact, understand age-related changes and its impact on how we deliver care, and appropriateness of prescribing and deprescribing. What needs to happen in the healthcare system to support population aging? Well, I mean, I'm a bit biased as a geriatrician, but I would say arguably we need to increase the number of geriatricians. So currently there's only about 300 geriatricians across Canada. If you want to put this into perspective, so I'm the head of the Department of Medicine, and I can tell you at the University of Calgary and in the Calgary zone, just within one zone, I have over 100 general internists within my department and over 60 gastroenterologists. And that's just in one, relatively small city in Canada. So if you think of it, if you comparatively, we're talking with 300 geriatricians across all of Canada for the entire population, and Alberta is just a small sampling of that. We also need to ensure that all if we look at how rural Canada compared to urban Canada, rural Canada is actually aging faster than urban centers. So we need to make sure that rural Canada is actually also supported with geriatric services and that they aren't just a service that is in our larger centers. So we need to look at appropriate funding models to support this. We also need to develop subspecialists with a geriatric focus. So things like geriatric oncologists, geriatric cardiologists, geriatric trauma specialists, orthogeriatricians. Because remember, as I said, access to care for older adults is impacted. Ageism is impacting that. So if we don't train various specialists, whether they're physicians or nurses or other healthcare professions that work in these various specialties, we'll continue to see ageism in how medicine is practiced. And then lastly, we need to be considering GEM nursing, which is geriatric emergency medicine nursing, within all our urban EDs to help with good care when they do present to acute care, and also consider adding occupational therapy roles. So in conclusion, ageism has negative impacts on individuals, on our society, and on our healthcare system. So it's costing our healthcare system billions of dollars. Well, maybe in Canada, it'd be millions of dollars. In the US, it's billions of dollars. With the rapidly aging Canadian population, changes are needed now, both within society and within our overall Canadian healthcare system. These changes need to focus on policy, on education, on research, and also on intergenerational interactions. And I'm happy to open it up to questions. I will stop sharing.
Thank you so much, Jayna. Excellent presentation. I can see there are some questions and some comments starting to come into the chat box here. Jill Chambers is giving a shout out to supporting the Third Action Film Festival in Calgary, June 10th to 12th. And she's posted the website there as well. So thanks so much for that, Jill. That's great. All right, just jumping down, I see a question here from Maureen. Maureen is asking, in order to get more educated healthcare practitioners, should the government be offering incentives?
I think there probably is room for some incentives. I particularly as a physician that is a geriatrician, geriatricians are one of the lowest subspecialties, and we've increased the cost of medical education over years. So, there's a bit of a disincentive sometimes to go into geriatric medicine, when you have huge debt loads coming out of medical school. So potentially looking at pay equity, and there had been some moves in various parts of Canada, so different provinces that have looked at that, and there's been some movement that way. I think, though, probably the fact that we are an ageist society, and we don't value people as we age. We're not, without addressing that, it's hard to say whether we'll actually move the dial much on encouraging people to go into medical healthcare professions where the focus is on looking after older adults, because we have sort of these views, both conscious and subconscious ageist views. So I'm not sure. I think probably we need to do more and spend the resources on actually changing, and similar to how we've looked at getting rid of other forms of discrimination, we need to actually focus even more on getting rid of ageism.
Thanks for that, Jayna. Interestingly, I've had the privilege of being involved with an organization here in Calgary called Linkages that delivers intergenerational programming, connecting students in schools with seniors living in long-term care in the community. And we've seen some students coming out of that experience who have chosen to go into careers working with older adults, including geriatrics. So that might be part of that more upstream. And you did highlight some of the ways that intergenerational programs might be one of the things we can look at. Mary B is asking, why are we not encouraging elders to use preventative medicine? For example, massage, chiropractic, acupuncture. Why are there not tax breaks for using preventative healthcare?
Well, and arguably because of I think the evidence around staying physically active, arguably we probably should be encouraging society in general and doing more to encourage physical activity. So, I think the idea of looking at our park system and not just designing parks for children, but actually looking at park systems where everybody can be active in the parks, and designing, accessible walkways and things, and also access to physical activity programs. I think could have, and from the study, it has to start relatively early in life, right? That one study was people in their 40s, and probably, even before that, learning healthy lifestyles. So, I do know Calgary and Edmonton are both looking at, age-friendly cities, where they're looking at things like accessibility to various things. And part of it is around sort of how they design parks and making them more accessible to everybody. So, the evidence for some of the other things I think is not quite as clear, but definitely there's lots of strong evidence around physical activity. And then the other thing, right, is access to good nutrition, which is an issue too. And probably we should be looking at programs to make sure people have access to good nutrition. And I know with COVID, there's been look at, even, in facilities too, we're not necessarily ensuring good access to good nutrition within all the facilities, long-term care and continuing care as well. And sorry, I apologize for the barking dog in the background.
No worries, and thanks so much. Dorothy is asking, as a subspecialty of internal medicine, is there an issue with limited space for geriatric residencies, or is there a lack of interest?
So, usually it's more of a lack of interest, although it cycles. So I do know in Calgary a few years ago, we had more people interested than we could offer spots. Although that being said, I think it tends to be the same sort of 10 to 20 people that are applying across the country. So, it definitely is an issue with people not particularly applying. So, we have a few excellent training programs spattered across the country, that are producing great geriatricians, including, in Edmonton and Calgary, both have pretty active geriatric training programs. But, if we look at it's typically the numbers that go into geriatric medicine is less than 20, whereas we compare it to cardiology, they usually have over 60 residents across the country every year. So, I think we could potentially create the spots if there was more interest, but it's a bit of chicken and egg, I guess. And I would say people need more exposure to geriatrics and a better understanding. I find a lot of my physician colleagues and other healthcare workers don't really understand frailty, and they don't really understand geriatric medicine. So, early exposure to it might interest people, in it as a specialty, because that often can be, I'll be on a rotation with some third year residents, and they'll be like, oh, I wish I'd understood geriatrics when I was choosing my subspecialty. Now, that being said, there's also lots of groups that never get exposure at all. So, in medicine, most of the opportunities to rotate in geriatric medicine are given to family physicians and to internal medicine doctors. People like surgeons and and some of the other specialties don't actually ever even get an opportunity to rotate with geriatric medicine to even understand geriatrics. So there's huge gaps. Overall, I think arguably not every physician will become a geriatrician, but I think every physician should be getting more exposure to older adults. And I'd like to say there was an article actually we published in the CMAJ a few years ago that showed that every medical school has a mandatory rotation in pediatrics, even though a large number of physicians will never significantly interact with children in terms of their healthcare delivery, whereas pretty much everybody other than pediatricians will interact with older adults in their day-to-day healthcare provision activities, but yet they're not being exposed to geriatric medicine or aspects of normal aging. So we definitely need more lobbying and more priority setting around the education of healthcare workers and early on.
Thank you. I'm seeing a couple of questions here about the role of polypharmacy and how that can be addressed.
Well, and I think that speaks a bit to education too. So education of providers and the importance of understanding what polypharmacy is and the understanding of how hard it is to, adhere to medications with the more medications you're on. I do an activity when I'm on service with residents where I give them a pack of Smarties and I label them as different by color to different medications. And I have them lay out a day's worth of medications based on just them taking 8 different prescribed medications. And it takes them about usually anywhere from 4 to 10 minutes to lay it all out. And then they look at how many medications they're taking. We have a great discussion about, it's not just all about drug side effects or drug interactions or drug disease interactions, but also, a component of polypharmacy is just sheer volume, right? If someone's taking a lot of medications and the first thing in the morning, it's almost a meal in itself. And also, the chance of them actually taking medications appropriately are going to decrease with the more burden you put on them in terms of pill burden. And so, the valuable medications that they actually need, they may not be taking. So we need to be more responsible and think about prescribing. We're a very drug-driven society. We like to solution things by quick fixes, like by medications, when actually we should be probably writing prescriptions for staying physically active and eating healthy. And really be constantly rethinking. So it's a bit of education of providers, and then also an education of society in general, that not everything can be fixed with a pill. And we need to think about other ways to actually stay healthy and active. And much of geriatrics is about what we call non-pharmacologic interventions to actually keep people healthy and active and high functioning.
Thank you. A few more questions I'm seeing here on the theme around how to address ageism in healthcare, both at the systemic level and also, I think, more at the individual practitioner level. So first of all, what would be some first steps you would champion to address systemic ageism in healthcare systems? And as you noted as well in your presentation, of course, COVID really shone a spotlight on the situation, the challenges in long-term care, and perhaps the comparative lack of investment in long-term care as opposed to acute care. And so Anne is wondering, what would be some first steps you would champion around addressing some of those systemic level issues?
So the healthcare system is a reflection on society overall, right? So a lot of things that we follow in healthcare system is a reflection on society. So like I said, more and more efforts, from a societal level, from, if we think about health broadly, right, of not just being sort of the healthcare system, but about the social environment too, and how we interact. I would say, more time and effort and resources need to be put into tackling ageism in society and changing how people think about aging, and having more giving people as we age the value that they deserve, right? They're as we age, we don't become less valuable to society, although society likes to think we do, because we are very focused on our definitions of beauty tend to be people that are younger. We tend to only value people that are contributing in the active paid workforce, and there's lots of barriers that we could be looking at in terms of how do we value people right across the lifespan in our society. And I think that would go a long ways to changing the healthcare system. But within the healthcare system itself, just tackling, I think, like I said, embedding a better understanding of what is natural aging, what is frailty, what is the difference between frailty and aging. The fact that when you think about frailty, yes, a quarter of people over 65 are going to be frail to some degree, but that means that 75% of older adults are not actually meeting the definition of frailty, and are quite active and living quite independently in society, and that needs to be celebrated and understood, right? We get a skewed perspective of aging in the healthcare system because we often only see aging in the setting of levels of frailty, right? And we don't always appreciate that there's a lot of people that are healthy aging that aren't interacting in the healthcare system, and not age does not equal frailty, right? So I think maybe a bit of understanding that, and I know there've been efforts in various curriculums in Canada to try to increase the exposure to healthcare providers as they're training, as they're developing into, into being part of interacting with groups where we can see successful aging and what it is to be active and healthy, and how to support that. I don't know if that answers your question, but it's a big issue to tackle. As long as our society is so ageist, it'll be really hard to tackle it within healthcare, I think.
This question might be in a similar vein. Heather is asking, how might we encourage physicians to refer geriatric patients for specialist assessments? I have repeatedly encountered a rather fatalist attitude among some physicians who don't seem to feel it is worth referring patients who are older and presenting with symptoms of decline and there is no diagnosis.
Yeah, so I didn't cover it in this talk because the talk was more about ageism, less about frailty. But there is evidence that actually, if an older adult that is experiencing early frailty, so mild to at most moderate frailty, if they actually have a comprehensive geriatric assessment, so either done by a geriatrician, but usually with the team, there's actually evidence that there can be impact on the progression of frailty. So, there is value and if you need to do it, the assessment needs to be done earlier on, because if someone reaches to the stage where they're quite advanced frailty, then the success of any intervention becomes less impactful. So, there is literature, it's evidence-based. So, when you're interacting with providers, I think pointing that out, that there's actually, there is evidence of a comprehensive geriatric assessment actually having an impact on frailty. It's one of the few interventions that actually have been shown that, and the other intervention is what talked about in healthy lifestyle. So staying, physical activity and healthy diet, particularly diet that has appropriate protein in it, can also impact on preventing frailty.
Great, thank you, Jayna. I'm just noticing, oh, there, and it looks like it came down. I'm seeing a couple of comments, questions related to the overall issue around, I think, healthcare policy. Should we be advocating for a shift towards supporting older adults more in community? And a shift away perhaps from our very acute care focused delivery, and perhaps even more broadly than that, just noting as well that a number of the initiatives that you highlighted really fall even more broadly into the purview of the social care sector, municipalities, municipal planning, parks and recreation, that kind of thing. Should we be advocating for a shift towards supporting people in the community?
So I think we're going to have to address this at all levels, but I do agree that often too much emphasis is put into acute care, and I think actually if we think about the first wave of the COVID pandemic, it highlighted about this as an issue. So maybe less so in Alberta, where Alberta Health Services had closer linkages with continuing care, but places like Ontario and Quebec, they spent all their initial efforts on preparing the acute care system for what was coming. And if you remember from the first wave, that was the wave where really COVID was really the first wave hit continuing care and less so acute care. Really, it was probably the smallest wave from all the waves on acute care. And so we basically didn't prepare properly. We totally ignored the fact that it was going to impact other aspects in the acute care system, the pandemic, and not providing something as simple as appropriate PPE and other endeavors. So I think the pandemic shone a great light on the fact that our healthcare system is not just about acute care; it's about all aspects of health and about people living in their own homes, about people living in continuing care, and then the healthcare system. And I would agree too. We need to think when we think about health, we need to think about wellness and well-being, and about the psychosocial aspects of health and wellness and successful aging. So I would agree. I think there needs to be better linkages across the healthcare system with social networks, and it actually will improve the health of not just older adults, but lots of populations, if we focus a bit less on traditional models and sort of facility-based models of care, and think more broadly. So I think we do need. I mean, we're always going to need some degree of facility-based care, whether it's acute care or continuing care, but we should be continue to investing more. I would say Alberta has probably done more than a lot of other provinces. We have a pretty extensive offering of home care services, and we have, because of the one provincial healthcare system, there is, like I said, closer relationships between continuing care and facility living, and the creation of the primary care networks and their whole, the patient home model has been really helped to support
I think your audio cut out there briefly, Jayna.
Either, and probably overall our silos in government also are putting barriers to really optimally optimizing the health of our society.
Thank you, Jayna. I lost sound from you there for the last few seconds of your response, but I think we did catch most of it. And just a good comment here from Sharon that's very much related, I think, that the AAG is going to be hosting a webinar on social prescribing in March. And so that's one of the mechanisms that might be able to help with supporting that connection between health and more of those social kinds of elements. Good question here from Linda. Do we need a Bill of Rights for older adults, especially in the context of the great difficulties that we saw exposed with COVID, and we knew about many of the things that should have been done for so many years. And Linda's asking, would a Bill of Rights for older adults be a way to finally support change?
I think that's probably not a bad idea. I also think we need to go back and look at some of our policies in general within healthcare and within the social system, and make sure they're not written in an ageist way, whether it was purposely or unintentionally. So I think probably we need to, and be more thoughtful when we're writing policies, to make sure they're not overall, that their policies and procedures and practices are not ageist. And a Bill of Rights may offer a framework to help us do that, potentially. So yeah, that's something I think that we could be doing.
Thank you. Rose is asking about another one of those important social elements around the role of appropriate housing. And she's wondering if you can comment on that.
Yeah, and so I know there's a lot of looking at, particularly, I think, the interesting thing about seniors housing, right, is anybody that's sort of been in this space, and a lot of you have been, it's been talked about for years, right, but not a lot of traction. And now I suppose the one silver lining of the pandemic is it's highlighted things that a lot of us knew, for years, that we needed to be looking at sort of how we care for people that, need assistance in activities of daily living and in healthcare, and that, in sort of day-to-day chronic health issues. So I think, there is there is, in Alberta and beyond, they're looking at, smaller facility living, right? So instead of these large facilities, is there some role for sort of more home-based smaller facilities? And, and also I think even in how we, a lot of the rules that have come out in terms of how facilities and how many people can be in a room, and how you make the environment and how you encourage social interaction, even when you have times of social isolation, and the incorporation of outdoor spaces, and the importance of outdoor living and active living and social interactions. And there's lots, actually, I think, that ways to look at it. I don't think there's going to be sort of one solution that we can, we won't be able to just abandon what we have, the current sort of structures we have now, but we can definitely, I think we can learn from people like in Australia. There's been a lot of work in Australia looking at remodeling some older facilities to make them more like a lived, a home-like environment, and looking at ways to improve the quality of life, and the quality of care that we're providing in some of these settings. So I think we're going to need to be looking broadly at a lot of alternatives, and not. Brenda, Strafford in Calgary is looking at, a model where they're going to kind of mix that. They're rebuilding one of their facilities there. It's called Clifton Manor. They're building, they're going to build a Clifton house in a village. So they're actually building a, seniors facility that also will have, sort of bring in the community and have aspects of community as well. And so looking at those designs, I think, it's about bringing the community into the facility sometimes, and putting in, there are other facilities that have been recently built where they have like interior gardening areas, right? So it's a great environment that everybody can enjoy, outdoor spaces, and incorporating, putting in coffee shops and things like that into the facilities that everyone can access. Make the facilities part of our social network, right? Instead of these boxes that nobody ever interacts with.
Yes, exactly. Yes, so many innovative approaches that we're seeing out there now. Comment here from Anne. It would be great to see uptake of gero specialties in medical training. Also appreciated disentangling age versus other contributing factors when predicting outcomes, i.e. rationing healthcare. Thanks for the insightful presentation, Jayna. Another comment from Maureen: we need to pay more attention to the mental health of the frail, as they need to move from independent living to some kind of facility. I know one person who became clinically depressed as she lost her independence. And Dorothy's asking again about the importance of opportunities for intergenerational contact. Which is something you definitely highlighted in your presentation.
Yeah, and I think, like I said, it's how we build our community spaces, right? So that they're accessible to all. Would be a great place to start, right? How we develop our parks and our recreational, and other sort of spaces that we all should be enjoying. So to encourage intergenerational interactions. And like I said, and in schools, incorporating, older adults into the teaching of younger generations, because they have a lot of knowledge to share.
Yes, absolutely. Seeing a couple of comments here on the idea of the smaller home design. Again, one of the ways that the way we design spaces might make an impact in opportunities for people being able to interact. For these homes to be part of communities, and not just a big box, as you noted. All right. All right.
One comment about spouses. My understanding that what came out of the recommendations in Alberta out of post-COVID was actually to address that issue, because I agree that you have people that have lived, been married for decades, and all of a sudden one needs a higher level of care than another, and they get separated, unwillingly, and we haven't been very flexible in how we, make determinations about where people will live when they need help with the activities of daily living or medical care, and they're looking for supports from society. And so my understanding that came out of the recommendations to Alberta was that we need to be doing more to support couples to stay together, even if their care needs were not matched anymore. So hopefully that will move forward. There were some really great actually recommendations that came out from the document that, as I reviewed it, from Alberta around what changes were needed post-COVID. So like I said, maybe that'll be a bit of a silver lining to the pandemic.
Yes, thank you, Jayna. Yes, I think you're referring to the facility-based continuing care review report that came out last spring, and it is posted up online on the Government of Alberta website if anybody's interested in looking at that, if you haven't seen it yet. Just watching the time, but we're still getting some good questions and comments, so we'll see if we can squeeze in one or two more here before we wrap up. A good question here from Madawa. What are some examples of research on ageism being translated to practical real-world impact, specifically in Alberta?
So I do know there's research going on in Calgary. So there's a researcher at MRU and also a new researcher that's been recruited to Calgary that's looking at outdoor spaces and accessible outdoor spaces, and working with the city of Calgary and Parks and Recreation around accessible outdoor spaces and the idea of intergenerational outdoor spaces and the value that outdoor spaces can have on our health and well-being. And so there is, if we think about from an ageism perspective, right, there was some, increased exposure to positive, role models of people aging, or just increasing intergenerational activities. So there is some research going on, and we do actually, I'm working with the Brenda Strafford Foundation and the Brenda Strafford Center on Aging, as well as these other researchers, to kind of look at ways to actually get the infrastructure in place to actually study that further, and study other aspects of how do we rethink continuing care, and how do we improve sort of that environment. So there's lots going on in terms of that space. And so, I would just keep an eye out for some of that, and hopefully you'll see it. Hopefully we'll start to see that our communities, actually, there are more space, sort of outdoor spaces and other spaces that encourage these intergenerational and opportunities for successful, role modeling for other generations.
Yeah, that sounds really cool. Thanks for that example. Sounds like a great topic, maybe for an upcoming webinar, actually. Yeah, and thanks so much, Sharon. I see that Sharon has posted the link there to the MNP facility-based continuing care review report. And just lots of comments and thanks to you, Jayna, for taking the time to share your thoughts with us and all of your knowledge and expertise on this important topic. And just want to thank everybody for attending and taking some time out of your evening to participate, and for your excellent questions as well. Really enjoyed this. And just want to mention briefly here before we close that the Calgary chapter is planning another webinar for sometime in May. So please keep your eyes out. We're just working with the presenter to nail down the specific date, but it is going to be on the topic of ageism and the media. So something that you mentioned, Jayna, in your presentation, I think it's going to be really interesting. We're looking forward to it. So please keep your eyes out for information on that to be coming into your email. All right, well, thanks so much again, Jayna, and everyone. Really excellent time, excellent discussion this evening.
Thank you, and everyone have a good evening and a great long weekend.
You too. Thanks so much.
Thank you. Bye.